Why people keep saying that NHIF works is because at their point of need as a patient, it served them. The only person who knows NHIF was not working is the provider who's unpaid, is the NHIF that did not receive the money it's supposed to use to work. It is the NHIF that cannot control the in-house fraud that they're dealing with. It's all those things. And those things are now the provider's job. Who is the government? The one who we hold accountable to provide us the highest attainable standard of care.
An estimated 1.1 million Kenyans fall into poverty each year. And that's because of healthcare costs. Would SHA, SHIF, UHC change that? Or is there more? Or perhaps, what's the difference between a pharmacy with a blue cross and a green cross? What about cancer and the rising incidence amongst the youth? Is it just lifestyle changes or is there more?
Women's health, men's health, your children's health, the economy, this and more awaits you on season 2 of Kenya's favorite health podcast.
My name is Dr. Diana Wangari, and welcome to season 2 of the One Health Lens podcast.
Hello, welcome to the One Health Lens podcast, where we have conversations around health and related topics, making them simple and easy for you to understand. I'm your host, Dr. Diana Wangari. Today in studio with us, we have what I would say a full house. And it's because I think we're about to have a hot conversation. But we're actually here to have a conversation around health financing, right? And it sounds complicated, but fundamentally what we're saying is we've seen a shift in Kenya around healthcare. We've seen universal health coverage, we've seen 4 acts. There are so many questions that have been coming up and people have been asking, why do we need to have this change? So we have in studio with us important guests who will let them introduce themselves and then we'll get going. I'll start on my left.
Thank you so much, Dr. Diana. My name is Dr. Elizabeth Wangia from the Ministry of Health. I'm a health policy and health financing specialist. In the past, I would say the past year and a half, I've been spearheading all these health financing reforms, some good experience while at it. And I'm really glad that I was honored to come and share with the Kenyans and, you know, Kenyans in general and other people. Well, yes. It's not just Kenyans. Yes, I'm honored. Thank you.
We've been looking for you. Dr. Matiko, intros.
Yeah. Good. So I'm Dr. Matiko Riro, medical doctor, health economist, currently working with the Clinton Health Access Initiative as the Associate Director for Health Financing. I lead our health financing reform, technical support across a number of countries in the continent. Yeah. And I happen to have been fortunate enough to lead similar efforts and support the Kenya UHC agenda for the last couple of years. So really happy to be here. Thanks.
Dr. Nelly.
I'm not sure I know which hat to wear today. So I'm just going to be the patient advocate.
The patient advocate.
Dr. Nelly Bosire, obstetrician and gynecologist, practicing in Nairobi privately. Definitely work a lot with them at the Ministry of Health and Policy. Work with the Medical Council with regulation and many other things. Yeah.
I tell you, you're the patient advocate, the concerned citizen.
Yes.
I hear
and the
you.
Service provider.
And the service provider, I tell you, the one putting everyone to task today,
you know.
Right? I mean, we've had these conversations every week, right? Different guests, we've been talking to concerned Kenyans. There are questions out there. And of late, you have started by asking people, one, have you had to go to a hospital recently, you or your loved one, to seek care, and what has been the experience, right? So I'll start from the concerned citizen. What has been your experience? Have you had to actually go to hospital or have someone seek care? What has been the experience?
right now, tomorrow, my uncle is actually going for brain surgery. And we have been trying to do this for the last 6 weeks. So finally we're ready, and pre-authorizations were sought, but the surgeon was not able to operate on the day that was planned for. So when they were rebooking theatre, they were told, oh, it lapses within a week, so you have to redo this again. We didn't have that with NHIF because, of course, of all of these unforeseen things that could happen. So again, so I was like, okay, well, first they're agreeing to approve at this point. But one of the things that we had to deal with was that for this approval to be given, we had to use very specific institutions. Like they are the what do you call the bespoke institutions that are getting through pastoral quick, and the rest will just have to chill. So your option, your choice of facility may actually not work for the patient and the procedure required. Not blanket, may just be that for specific procedures it might not work. So we had to then be forced to use a hospital, which was not our first choice by any means. Because it's a place where they were going to get the full package. He's having brain surgery. It's going to cost us about $1 million bob, and Shif is paying about 504,000. But we will only get that amount in like 2 hospitals only. So one, the doctor doesn't have admitting rights there, and the other one was not exactly our choice. So we're kind of not really having the freedom of choice as we would like. Yeah, and then of course appreciating that yes, there's only so much they will pay for.
So you'll still have to go
still
out
have
of
to raise
pocket.
The remaining 50% is coming out of pocket.
Okay. Dr. Matiko.
Yeah, I think for me, the last time was sometime last year. So, my son has frequent attacks with crew, right? And, it happens usually very early in the morning, like 4 a.m. And so one of the things I noticed, especially in that whole experience, was just the whole process of just before you're seen, what sort of documentation you've got to fill and all that. So the real action might take like 30 minutes to sort this, but the process of moving from one desk to the next to just get documentation, present cards here and there. I mean, I think for me, it's just the operational inefficiencies that exist within health facilities, especially within the private sector. What kept me worried, and I get the same feedback from a number of people, that going to the facility, there are too many other processes. You feel like something could be done about it, because you'll go there for something that is quite quick to just nebulize, but now it ends up taking forever. So what I opted to do since that time was to buy a nebulizer myself, to be doing it myself, because this is something I can do for 30 minutes, but it ends up taking like 3 or so hours in the hospital, just going through papers. Yeah.
Okay.
Yeah. So for me, I would explain myself in 3 instances. One, myself as a patient, I'm of course together with my family. Then based on positive and negative experiences. So having walked this journey of health financing reforms, as you know, as civil servants, we have the civil servant scheme. But then seeing the difficulties facilities go through in getting the reimbursements, we all know that their NHIF was owed a lot of money from Public Service Commission. Many times when I needed to seek service, I would opt to just pay out of pocket, especially like if they're outpatient. Fortunately, they were mainly outpatient services, some dental, because I was telling myself this provider will take forever to be paid, and I opted to do that. So, and now with the post-rollout, I've had the 2 sides of the coin. There have been those people who have actually sent us feedback and told us that we walked in and out of a facility having paid nothing. But then there are those, even there was a discussion earlier today where someone had to pay, say that they had to pay for their brother out of pocket 200,000 because the procedure they needed was not listed within the benefit package. So I guess at the end of the day, I can say it's all mixed. You'll always get some people who are happy with the service and others not happy with the service.
Okay, I mean, but we would say, given just what we've been hearing, right, and different experiences, majority lean towards one side, right? Majority would say they're having a challenge. Challenge can be, depending on the resolution, can be good or bad, right? So then the first question everyone has been asking is why we needed to change, right? Why was it important to have this change, right? And I would start with you, Wangia, right? Why would you say we needed to actually have this change? Because most people would say even if things weren't working, at least there was progression, continuity of care, right? Right now it seems there's some interruption. Why do you think, why did we need to change?
I really like that question, specifically, especially in this digital era, because I can just equate it to a Pentium 4. Yeah, because if you had a Pentium 4 computer, however much you do an upgrade, whether you expand the storage, you do whatever it takes, it will never work. You just need to get out of your way, get a new Core i7 and do the thing. So that's how I look at it. But this is acknowledging, of course, that in between you could have done maybe better in the transition from the Pentium 4 to the Core i7. But in essence, when you think of an organization that is meant to run your entire scheme, where our target is 85% insurance coverage. If we are to think of an organization, you don't think of what that organization will offer right now. You think of, is it ready to offer this service in the next, many 5 years or so. Key thing, there were very fundamental things that needed to be improved. And basically what we did is we had recommendations from what you call the health financing experts, health benefits expert panel.
Matiko, are you in that panel?
Matiko,
you tell us.
They sat in a hotel in Nairobi close to 6 months and came up with very good recommendations. It is close to an 800-pager report on, it's called the NHIF that we want. And sometimes making a change when you are within can be a problem, can be a challenge. If you tell me to make some change even in my house and I'm in that house and maybe that change is working for me, the status quo is working for me, it becomes so difficult. So sometimes it needs an external person to come and actually make that change. Number one thing is this issue of accreditation. And thank God Dr. Bosire is here. This accreditation of facility, that was the entry to fraud. If you're thinking of fraud, close to 40 to 50% of resources were being lost through fraud. The entry point to this was accreditation. That function had to be taken away from NHIF. That was a recommendation by the experts panel. And even when the NHIF Act was amended in 2022, it wasn't done. So yes, there are things that you could say you want to make progress, but you realize there are things that could also face resistance because of people who are used to the status quo. So that was the number one area. Number two area was even in the governance. If you look at the governance, how the body is constituted, the board was largely representation. So you're like, oh, we need someone from civil society, we need someone from the county. But now one of the recommendations was about bringing professionalism to the board. So that even if you're getting someone from the county, can this person from the county be a professional? You're not just getting just any person so long as they're from the county. Civil society, you're not just getting anyone so long as they're, so that's that aspect of governance, because governance is core to any institution. Then just this aspect of benefit package. I can assure you, just this process of developing the benefit package, I spearheaded that process. And let me tell you, it's crazy. The amount of lobbying that happens. And you can imagine if you are the same institution, then you have everything it takes to lean to whoever lobbies the most. But in this case, this is one aspect that had to be taken away from that function of SHA. So that we are saying we want to, if it's development of the benefit package, this inaugural package was done by the ministry. It was spearheaded by the ministry. It wasn't even spearheaded by NHIF. We got, of course, actuarial support and some of the other support because we didn't have that capacity, but the drivers were the ministry because we consider ourselves more independent. But moving forward, actually, it will be based in the ministry, but linked to a research institution. So you can imagine some of these fundamental issues had to be addressed. Finally, and this may not be the final 2 points, the digital system, fully that this SHA will be fully digitized. It was a strong recommendation from the advisory panel, and the dispute resolution, because you can't be the one causing the problem, addressing the problem, solving the problem. Like, you can't be everything. So we're saying in case of any dispute, this will be handled by a different body, which is more independent, and there are clear regulations as to how this dispute resolution tribunal will be constituted and how it will run its business. Not forgetting administrative costs. Administrative costs for NHIF were not capped in any part of the law, and but now we are saying 5% admin costs. So you have to use innovation and whatever it takes for you to be within the 5%. Yeah.
I mean, Matiko, we all listened.
I've
We all listened.
I've listened to Liz, and I know we've had this conversation in Liz quite a number of times, but I think there are a couple of things that I agree with Liz. That one, NHF, there are lots of sentiments that NHF was working, well, we're fixing what was working, but one of the things that I have to also confess, probably from my own observations, and the fact that I've provided technical support to the ministry and a couple of others, it was working for a few. But the thing is, the few managed to have big voices and to speak louder in terms of, yes, it was working. But actually, if you look through the whole scope of people that are not able to access the services, is quite big. And in that working, for the few people, introduced a lot of complexities. That, for example, when you look at the inequities that existed within the schemes, that there were few people that received bigger benefits than others. Of course, you can argue and say, yeah, but the contribution was more based on other factors. But if you are to come up with a real social insurance, part of solidarity, one of the key items that we have to think about is equity. How do we take care of the other people that actually have no voice, that can never speak whether it was working or not? So what are the drivers of NHF, probably at least from a technical standpoint, or working for many? I think Liz has highlighted a couple of them. That administrative cost was pretty high. It still remains opaque. No one knows what that was. Others will quote 40%, others 20%, but it's neither here nor there, because again, there's a whole conversation around what the different bodies supposed to submit their money actually submitting the money that NHF needed. That's a whole other conversation. Probably they can tell us whether there were commitments around it, or they actually honored with the real money, because there's a difference between allocation and actual disbursement of the money. If there are commitments around civil servants scheme, what the money actually sent was Edwafia, was the money actually sent? So those are other questions that probably we don't know. They probably know it best. So let's go to the transition, because I know Liz has talked quite significantly around what the problem was. So you'll argue and say, so now that this was not working for many, was it necessary to literally just throw away what she's called the Pentium 4? Or there were actually efforts around HEFREP report that she mentioned about that potentially brought a lot of issues. Of course, the argument is fair that maybe there was a legacy issues, especially with the people that were within. They were party dependent, especially in terms of what they're used to doing. Then we can say, okay, good, so let's go to a new one. But how do you make sure that even as you're transitioning, you still, the service entitlements of the population are still maintained? Because if I was entitled to maternity services, am I still entitled? If I was entitled to this, how do you transfer that entitlement without that sort of service disruption? And that's for both patients and care providers, because then how providers are treated, especially in payment, defines how, because incentives, this is all about incentives, defines how they provide the care. I think that transition, to be honest, especially the last two, especially based on the voices, either from the patients or providers, that has not been handled well, and probably there needs to be seen how best to provide that moving forward. Then the other, in terms of that transition, is basically going back to the aspirations as at least listed within the laws. That what was the role, what are the different roles of the different people? So were they really honored? So the government was supposed to commit funds. Have they actually? So it was written, documented, but in terms of the budgetary allocation for this financial year, you can clearly see it wasn't.
Because one of the fears most people have is we all sit in rooms. And it's fair. What? technical expertise, give them time, let them evaluate, then come up with recommendations, right? Fair enough, right? Then, but fundamentally, it comes and impacts human beings, the Kenyan, right? So, and a very direct question would be, in these recommendations, right? Definitely something was wrong, needed to be improved, right? When you're making the recommendation, was there a recommendation on how to implement? Or was it just a recommendation that this is what's wrong, needs to be changed? Was there a recommendation on how to implement?
Yeah. I mean, the 800-page document that was
so
preferred
there was a recommendation.
Actually, all, and including timelines. There were action plans around how best to move forward.
Okay.
But again, it's, looking back at it, probably it was overly ambitious based on some of the issues that Liz has highlighted, that you're talking to maybe you're talking to a Pentium 4, a Pentium 5. Probably that's a fair argument. But again, there are all the other conversations around how then do we handle that transition to a Core i7 without necessarily having to improve other things? Because I can still take the same laptop and literally go upload a new one. Have I changed the RAM? Have I changed this? If you talk about the same things. So I feel like there are certain foundational stuff
that weren't addressed,
that are not yet addressed, and probably I can give the benefit of the doubt that those are the things that now other laws such as the PHC strategy and the Digital Health Act and a couple of others are working towards. But are they going at the same speed? Are they going in tandem? Probably that's a challenge.
So definitely there was recommendation that this is step 1, potentially we need to address step 2. And so this was tabled, and eventually it was for implementers to say, okay, fine, we are going to implement it as we see fit, so to speak. Right?
Yeah, absolutely,
Okay, fine. Nelly.
That's interesting. I know she changed from Pentium. Now, what the government actually did is that it moved house. It actually left
we moved continent.
House and just moved continent. At this point, frankly, I don't think I care. Is it NHIF? Is it SHIF? I don't care. Me, I want it to work. Okay?
Yeah.
Now, my struggle with our ministry, and you do an amazing job.
Absolutely.
But you fail in appreciating the voice of the user. Not once, not twice, not 3 times, 50 times. I like how ministry talks as if NHIF used to belong to another ministry, and now SHIF belongs to ministry.
It's a new ministry. Everyone has changed.
NHIF is a state corporation of the Ministry of Health. When you tell me about corruption and fraud, Aki, before the ministry knew about it, we told them how it was happening. They put no effort whatsoever to curb it at NHIF. So I don't expect that when the new fraud, because fraud in this country is going nowhere. In SHIF already, they're figuring it out how they're going to be defrauding SHIF. So if you didn't try to curb the fraud at NHIF, what makes you think you're going to curb it in SHIF when we've given you bigger money?
I mean,
so for me, that's a problem. NHIF's fraud was not even rocket science fraud. There's no way a hospital can treat patients who are not treated and bill. There's no way children will leave school at 3:45 and queue outside the hospital and be given 50 shillings, 300 of them, so that this guy can bill for 300 bob per child. I went to inspect a hospital as part of KMPDC in Western Kenya, and there were 47 babies admitted in the ward. And I'm like, why are these children in the ward? They're walking around, they're playing, they're telling stories. They were sick. Oh, they had malaria. I said,
why are they still here?
Are you telling me that before we had these funds, children didn't get malaria? How is your ward this full? We talked and wrote and asked and said, look, so when you tell me we have seen this parliament enact forcefully 4 laws in 6 months, they couldn't sit down and amend NHIF to sort out those problems that they're raising. For me, that comes across as not very committed. But we like shiny new toys. So we're a shiny new toy called SHIF.
Yeah.
And frankly, I don't care. Me, I need it to get me where I am going. So I love what the economists are doing. Now I'm going to poke holes. Because now I am talking as a patient and I'm talking as a provider. Okay?
Yeah.
Why people keep saying that NHIF works is because at their point of need as a patient, it served them. The only person who knows NHIF was not working is the provider who's unpaid, is the NHIF that did not receive the money it's supposed to use to work. It is the NHIF that cannot control the in-house fraud that they're dealing with. It's all those things. And those things are now the provider's job. Who is the government? The one who we hold accountable to provide us the highest attainable standard of care. So I'm happy you sat down with these people and you talked about the money part. The money part. I need to know where the conversation of the quality part happened. It's never happened. It doesn't matter what you guys want to call it. It has never happened. Okay? So I hear, oh, there is a suggestion to bring a national quality body. No, by the way, we have enough bodies. We have enough bodies. We don't want any more. We have bodies that can deal with quality. They are called professional associations. Okay? When it comes to how to treat a child, it's only the pediatricians who can set the standard. That is why there's a pediatric manual they produce every year. You go to a KPA conference every April, you get a new one for the year. Sponsored by these guys here. Are you getting what I mean? I said, did the child have a sneeze? Oh, just give Piriton. Did the sneeze come with a fever? Give paracetamol. Is there looking that this fever has persisted for this, or we may need an antibiotic?
Yes.
What does that do? Is that if SHIF was now paying based on that, then we assure quality of health. Because when the guideline doesn't work and it breaks down, we know to fix the guideline, not the money. Okay?
Yeah.
When it comes to obstetric care, I'm an obstetrician. I don't even want to know about gynae surgeries because they're varied. But delivering babies has never changed. And if I sat down in a public hospital that has everything that is needed for bare minimum quality standard of health, the allocation they have given cannot work.
I hear you. In fact,
allow me to finish, please, because you started this conversation. Sorry.
No, it's okay.
But
Continue.
here's what I mean.
Yeah.
I ask this question all the time, and there's no way you can tell me that it is only me and Kigondu who are thinking about this. When did we start giving free maternity? It doesn't matter what it was called or whose president it ran under. For 11 years, we have said maternity care in this country is free. If this was happening in any other country, what would be the immediate impact of free maternity? Reduction of maternal and perinatal mortality. 11 years. Now, we're too embarrassed to face up to what the figures are. We're even saying we don't even know what data you're using to tell us that figure. But truthfully, even if we work with what MOH works with, it says we've come from 480 something. Actually, 455. By 2012, we're already down. We're not at the 480s. To 355. Is that commensurate to 10 years of free maternity? So all we did is we told women to stop delivering at home and deliver in hospital. We did not say that they should have quality, skilled care. Now we've transitioned to SHIF with the exact same problems. Okay? Now, when you give a public hospital a reimbursement for delivery, they don't pay rent, they own the building. They don't pay the doctor. My taxes pay that directly from the exchequer. They are buying oxytocin. They are paying the cleaner. They are doing so. That money, by the way, can look a lot to MOH, and that's okay. My problem starts when you give the same amount of money to a private hospital. That has to pay rent. It has to pay bills, electricity, water. Buy the same exact drugs that cost them more because they're not getting them from KEMSA. And pay the doctor and the midwife and whoever else is in charge. Quality, my friend. Shortcuts are being taken. So right now, 1 in every 4 cases reported to KMPDC is a maternal death. Please note, I don't even think that's 0.01% of maternal deaths that are happening in this country. And when you go through those deaths, you see those glaring gaps because there are little facilities in the Korogoshos and Kibet where we are so proud we've brought care close to the people, are fitting into that amount of money and still needing to make a profit. So our women and babies are being butchered because people need to make money. We did not regulate the quality. We call it an inspection. That means nothing. Okay?
Yes.
We then moved from there and said that now we're doing cesarean section. Even a vet will not accept those figures to neuter a dog. But we want those figures to deliver 2 lives. 2 lives, and we are talking about quality of care. When I looked at the share rates, we are supposed to be happy they are high. Oh, so because we've moved a CS from actually 27 to 30, we are supposed to be very proud. Okay? I am stuck at the same problem. We haven't cured that problem. And that is the woman. This year, she's delivering. We want to pay 30,000 for her cesarean section. Next year, she has an ectopic, where it is 1 life under threat. Do you know what they have given us? 135,000. Who's fooling who? Who were you treating? Who were you caring for? When I am being told my 2.75 is supposed to serve me and 2 indigents, and I don't have a problem with that, okay? But my 2.75 is 10 times what I pay my private insurer. Okay, and my private insurer gives me this quality of care where I can even choose my specialist, and I can even say I want a specialist. Yeah. Now, if you have decided that some of mine has to go to someone, then that someone surely should be given a qualified midwife who is well paid and who is delivering in a clean environment that was actually washed, where electricity was paid for. There's an actual baby resuscitator, because that's quality of care. We always say the one thing that a social health insurance is supposed to do is equalize. You deliver your baby, by the way, in Uptown and take them back to the slum, but the delivery for that baby, because that baby is state property and has to be treated as such, was the same. That's why I say I don't really care the vehicle, I don't care the ward, until I see a demonstration of how we are assuring quality of care. And I go back to a basic one that has worked for decades, the UK. We are not rich like them, and that's fine. We are not going to expect to deliver in a hospital that looks like Nairobi Hospital all over this country, and that's fine. But there's one thing that they are sure. They use their colleges to set the standard of care. So even if I moved from Nairobi to Aga Khan, to Pumwani, and to my dispensary in my village in Esani, in Nyamira County, the one thing I expect is that delivery is conducted with the same exact standard of care. If you can do that for me, all these issues that Mwananchi are complaining about will go away. And if we consider that seriously enough, then half of the providers have to be scrapped because they have not even invested enough to qualify to provide the bare minimum standard of care. You go to a hospital, the fraud that she's talking about, that NHIF would accredit a hospital at level this and level of what? Do you know, even before NHIF started accrediting, KMPDC, we already said, I was a full member then, and we actually had a meeting with the quality department of MOH and said, there's no way the payer can again accredit. And they refused to listen. So we're doing double accreditation. They said, no, you register them and license them. They will bring their license, we shall accredit them. Then over time, they said, no, now it's not working. Now let's go back to KMPDC. And of course, this corruption chain is not just at NHIF. It's an entire system. So even if we put how many things in place, we expect that even SHIF is going to go the same way. So for me, it's not about is the system that we choose or the vehicle that we choose going to eliminate corruption or not. No. Is the Ministry of Health seriously committed to say there will be no corruption? And we catch you once, for the next 10 years, you cannot be a service provider. The punishment has to be so painful, that people have no choice but to abide. We need to empower our patients so that they know when they're going to hospital and being billed for things that didn't happen to them, they know that even them, they will be incorporated as they are supporting the fraud. So that then everybody on this chain has no choice but to remain alert. So that whatever we're giving shift is giving the services required. And now we can come back to coming to talk about how we actually costing our package. Because what right now we have, and I know you're an economist, but what you did is you just priced them. You didn't cost them. We need to cost care. We need to cost true care. So that if I tell you that at normal labor, I expect you to use no less than this number of pads, this amount of gauze, this number of IV fluids, this and that and that. If you provide care without using those things, then it's not standard of care, because what shortcut did you take? You get what I mean? And that's where I rest my case. That's all I mean,
we did. I mean, there's a lot to unpack there, right? There's a lot. And I think an easy approach would be to say, let's first pack the technical elements, first of all, because that could be a subsequent conversation, right? And let's talk about the people who will be listening to this. They'll be thinking about the common quality of care, yes, being offered by service providers, but me receiving it, right? And the first thing that comes to mind is putting sort of a skin in the game, as they call it, right? That if we are committed to, this is the path we're in, we're not even no longer arguing whether we want to go back to NHIF. We are no longer arguing about those issues, right?
Yeah.
We're not even arguing about terminologies anymore. We're saying that we want to make it work, right? How do we make it work, right? It's either people need to understand so that it's a matter of time. These are being worked on, there's transparency. But more importantly, it's the commitment from, I think, the different parties that's coming up clearly. That the commitment, how can we showcase commitment? And I look at you, Dr. Wangia. Why? Because there's a question around even just allocation, right? Allocation, if you are to just look at the social health authority between what was contributory and what was tax funded, and we saw what was allocated, and most people were saying, if there's commitment to this thing, allocation will have been more, right? Because then maybe these were the other elements, what Matiko was saying, these were the other elements which haven't caught up with shift that are meant to support the other quality and service provision elements, right? But the government hasn't even allocated that, yeah? Now, the question is this. If we are saying we are committed on this path, right? How do we ensure that there is that trust being built, right? With service providers, with patients? How do we ensure? Because implementation documents are there. There's definitely brilliant brains behind it. How do we then showcase that we're working together? It's a journey.
Yeah. So thank you for that. Talking of commitments, I know when we did the costing for primary health care, the PHC package, it was way more than what we received. So was the Emergency Chronic and Critical Illness Fund. But to us as the health sector, we say it was a gain nonetheless, because previously under NHIF, we didn't have the PHC fund. We didn't have this 4 billion that we have right now. We didn't have the Emergency Chronic and Critical Illness Fund, of which the government allocated 2 billion. The other thing you need to remember also is that all of these services were to start in October. So basically, the way also we look at it financially, we run a financial year, even for whatever allocations. So you're talking of 3 quarters. So this 6 billion is actually meant to run for 3 quarters. The other thing we need to realize is that apart from the monetary funds that are available for healthcare interventions, there are so many other ways in which the government is allocating resources. Like, for instance, at PHC level, who pays the workers? That is government money. Don't forget that is actually a budget allocation. Who gives the commodities? That is a budget allocation. So yes, you may not see that line as PHC fund, this amount, going to all the facilities. But for the public facilities, of which that is a totally different discussion, between now the public, the private, you'll see that commitment. We all live in this country. We know we have a high debt burden. It's not like we live out of this country. Whether the debts that we borrowed, the monies that we borrowed were put into good use by whichever governments before, is not the topic of discussion. But the reality right now is that for every 10 shillings, we collect 7 shillings goes into paying debts. We have these 3 shillings to fight amongst all the sectors. So for us, the fact that we got that allocation, we wished it would have been more. It is a gain to the health sector. In addition to that, through one of the World Bank funded projects, remember World Bank money is actually government money, because these are loans we'll pay. The government will be providing commodities to primary level facilities. So yes, you may see the 4, but you're not seeing all these commodities that will go to primary level facility that have been allocated also, and all these other resources that go in as budget lines. So here I am, I'm a doctor, but talking more of the numbers, but I totally hear what also Dr. Bosire talks about quality. And if you just allow me to, in less than a minute, to just give a reflection. Quality starts right from the training. So it's not, you get the wrong training, you'll turn out the wrong people. And that's where the issues begin. And the fact that most of the time this training, we have to keep on working with the Ministry of Education. We tell them we need these numbers. They tell us they're training for the globe. They're not training for Kenya. Yeah, that they're training, it's a global, who said that the people you're training will work in Kenya, which makes sense. But then we also have our role to play. We can say, like in KNH, if you're to have these people, you cannot have maybe more than a certain number. So that one we have the control of, which I know these are discussions that are ongoing. So basically what I can say is we are not where we were, I would say 10 years ago. When I joined the ministry 10 years ago at national level, we didn't even have quality indicators. I remember I was in the monitoring and evaluation, and we didn't have anything to measure quality. But then now there have been things like the Kenya Quality Model of Health, the Joint Health Inspection. So you can see there are some initiatives to bring in quality, though we must admit we are not really there yet, because clearly, as you say, 2015, free maternity, we have not seen any. The only thing we have seen is an increase in the number of
attendance.
Yeah.
Without commensurate improvement in
so
outcomes.
We are not at there is no commensurate improvement in the outcome. Neonatal mortality has not improved. So these are things that really we need to question ourselves.
Fair enough. Thank you, Nelly.
Thank you.
We'll see you on the second part.
Awesome.
Good.